Okay, thank you. Well, we covered a lot, so we're going to start with a little follow-up questions here, and then we'll open it up to the audience. So, Bob, one of the examples you used to illustrate Mises's contention about intervention in the economy briefly was the whole healthcare fiasco of the past 50, 60 years. Could you delve into that a little bit more?
Well, sure. So, I mean, one way to motivate the problem is to say that if you notice, before even the Affordable Care Act came through, that a lot of people, if you get a good job, then you're fine. But if you're in between jobs, then you were in trouble. And so you notice that that's fairly unique to health insurance, right? It's not like you say to your buddy, hey, you want to go to this restaurant? And he says, oh, no, I'm in between jobs right now. I can't get car insurance, so I can't drive until I get hired. No one talks like that. But yet you might say, oh, there's this elective procedure. I'm waiting till I get a new job before I can pay for that to get health insurance again. So that was the way people talk. So you wonder, what was it about health insurance? How did that get to be the case? And so I'll just mention two things. So one was back during World War II, the government was running the printing press to help pay for the war effort, and they imposed wage and price controls. And so that meant, if a company wanted to bid away talented labor from some other company, it was illegal for them to offer them a higher salary in the form of money, but they were allowed to pay for health insurance premiums. And so that was one way, that was part of the reason that became a standard practice was, that if you went to get a normal job, that part of what the employer did was pay for your health insurance. So that was one element of it. So there you can see, again, the response to one particular intervention and the problems it caused was this new thing that then down the road would come back to haunt us. Another element that sort of ossifies it and keeps it locked in that way is the tax code. And a lot of economists talk about this. But just in case you've never heard the point made, that the way the tax code works is if your employer just pays you a bunch of money and then you go yourself and buy health insurance, that those wages to you are taxable income, so you're paying with after-tax dollars, at least on the standard framework. Whereas if the employer pays for your health insurance, then the employer still gets to deduct it, but typically the IRS wouldn't treat that as a benefit in kind that wouldn't be taxable. So for high-income people who were going to go get health insurance anyway, that was a huge savings. And so again, that's just another method by which the problem, the intervention being the high marginal tax rates. The only reason this is an issue is because marginal tax rates were so high at the top levels that then the government was sort of giving a loophole and giving you a method to get your money back that way. So again, this one intervention over here, high tax rates that you wouldn't think would have anything to do with health insurance, but yet was part of the reason that we're in this situation.
So here we are, John, and you talked quite a bit about this as well. But the million-dollar question that everybody wants to know is, are the Republicans going to pass a new health care bill that actually solves the problem?
Most people don't know how Obamacare is funded, but about $1 trillion comes from new taxes over the next 10 years. And who's paying those taxes? Drug companies who agree to be taxed, insurance companies who agree to be taxed, the Business Roundtable folks with all their self-insurance plans, they agree to be taxed. All these people agree to be taxed to give us Obamacare. So now the money is on the table, and we include the Medicare cuts. We're talking about $2 trillion over 10 years. So what's a good thing to do with $2 trillion? I say let's have a tax cut. But it's got to be a tax cut related to health care. The Pfizer's, United Health, and so forth, they're the last people who deserve a tax cut. I mean, they went behind closed doors, sold you out, and they all expected a profit from it. So now that we can reverse some of that, yes, use the money for a tax cut, but don't give it back to Pfizer, don't give it back to United Health. By the way, they're not even asking for it back. Ryan's health bill cuts $1 trillion in taxes, and the bulk of that goes to people who weren't even asking for a tax cut. And if you take $1 trillion out of health care, of course you're going to have millions of people who lose their insurance. So I don't know whether it's 24 or 20 or what it is, but it's a lot. And the Sessions-Cassidy-Goodman approach is, let's use that money to insure as many people as we can. That's why the Democrats put it on the table. Let's use it in that way. That's a conservative approach, and it reforms health care at the same time.
Well, one of the hallmarks of independent institute studies is we go to scholars and we ask them, analyze the problem. Why are we having these problems? And importantly, with John, with healthcare, what's led to it, some of the issues that Bob's talked about and so on. But importantly, a key part of every study we do is what alternative market-based solutions would actually solve the problem. And obviously when we undertook Future, that was an important part of it was, yeah, we want these people to look in their crystal balls and see the future, what's coming. But importantly, what can we be doing today so that it is prosperity in all of the ways that you talked about instead of peril? So Robert, what do you think are the best, what's our best hope for the future being one of prosperity over peril?
And so let me start with the kudzu problem and then move to entrepreneurship. And so the kudzu problem is that government plants this regulation. They prefer to regulate because they don't need to spend money. They don't need to spend tax money and raise taxes, and people hate taxes. And they can also use the regulations to pinpoint exactly who wins and who loses. Don't have to leave it up to chance. They can craft a bill that's that long and tells exactly who wins and loses. And so how do you fight back against that, right? You have to do it at the ground level with us being the goats, the voters that eat the kudzu, but then you also need to have the entrepreneurs step in and fill that void, right? And so, again, this is something that's done at a grassroots level. It's a cultural level, right? And so why, any baseball fans here? What country produces more great baseball players than any other per capita, by far? The Dominican Republic. Why? Better genes? No. Because baseball. When a new baby is born, they put a glove in the crib, and it's baseball from day one. And to some extent, the United States has been like that with entrepreneurship. It's been in our DNA. It's like, oh, awesome. We don't look down our noses at these people like they do in some other countries. Instead, we encourage it. And we don't want that to go away. That's the key, to tell our young people and to lower those governmental barriers to entry so that these entrepreneurs then can beat down the other barriers to entry like John Rockefeller built up. They'll build them up. The only way they're going to really be overcome is by other entrepreneurs. And ultimately, that's what broke Standard Oil's monopoly. Even before the Supreme Court case that broke them up, there were new entrepreneurs getting into the business. Some with very deep pockets, like the Mellons of the world and Gulf Oil down here. But, you know, all over the place. That's the way to do it. It's, I'd say, at this grassroots level.
Well, we have with us today, as David mentioned, Josh Umbehr with us, and he's a consummate entrepreneur in the very interesting area of healthcare. And as we all sit and wonder about this terribly complicated thing and how are we going to solve the problem and so on, you're just doing it. So could you tell us what you're doing, Josh?
Sure. I think we had wonderful speakers, each one with unique, specific, and global insight that can be applied to healthcare. A lot of it we're trying to do now. We started a practice in 2010 with the idea that healthcare was broken. Not that insurance was bad, that it's just the wrong tool for the wrong job. We started a membership-based practice, $10 for kids, $50 for most adults, for unlimited home visits, work visits, office visits, technology visits, no copays. Any procedure that we can do in the office is included free of charge. Stitches, biopsies, joint injections, bone scans, lung scans, heart scans, and much more. We further innovated into the space of adding value to our customers in the proud tradition of business by adding wholesale medications and labs. So we innovated past the traditional model because it wasn't regulated as much, which to our benefit. 44 states allow physicians to dispense medications to their patients. Well, like anything in retail, there's a wholesale price. It turns out it's usually 95% less than you're paying at a big box store. So Walmart will sell you 90 pills for $10. I get 1,000 of those pills for $8. So we can bring value to our customers in a way that hasn't been done before. If I save them money on their medicines, directly and indirectly, I make them healthier. And we can apply the same principle to everything in healthcare. And traditionally, an 80% savings is a good starting point. Labs, 95% savings. A CBC, a basic test that you might pay $50 to $75 for, depending on the setting, we get for $1.49. We mark it up 10%, damn profit, so $1.65. Now, we really change the paradigm shift in a way that's unexpected, in a way that I think is a win-win and that we try really hard to explain to people on both sides of the The left, again, wants more care for more people, arguably laudable goal. The right is not against it in a lot of ways, for better or for worse, but they want to be financially responsible or free market supporting in a sense. Well, if we can decrease the cost of medicine by 95% and labs by 95% and unlimited visits, haven't we just maximized the buying power tenfold? If Elon Musk can send a payload to the space station for 95% less than NASA, how can we come in and provide care at 95% less than what Medicare or Medicaid is paying? If we do, we've instantly increased their budget in a way that no other person could do politically or economically. But by putting the patient first and adopting sound business principles that continually add value. And so we do this throughout. The extension of this is we take this value to employers. We can decrease their insurance by 30 to 60% the first year. We've decreased some employers' health insurance premiums by 75% over 5 years while their company has grown. So if 70% of jobs come from small businesses, we could create an economic boom that would last generations simply by adopting sound business principles and applying it to healthcare.
Right, so we've solved healthcare.
What's that?
We've got consumer sovereignty out there. So now we invite questions from you.
Dr. Umbehr, enlarge your comments on how you work with a company. My understanding was that if a patient comes to you and you provide services, a patient gives you cash, how then does a company intervene in that relationship?
Companies have a lot more flexibility through partially self-funded insurance models, which are still a better alternative than the Affordable Care Act for individuals. So we want to fix as many pieces of the healthcare puzzle as we can, the two biggest being health care and health insurance. So if we can show the employer how they can use our model to lower their insurance costs, then that helps our business grow. So employers in a partially self-funded model, the standard used to be 50 or more employees, but we have insurance companies going down to as low as 2 employees. What the insurance companies are saying is that their profit margins are 4 times higher in employers that are working with our direct care model than the alternative. So we can go to partially self-funded and have really the ideal political solution without going through politics. We can customize that plan for every employer group for maximum savings or maximal coverage or something in between. But now you need less insurance. The classic analogy is car insurance. You don't have car insurance that pays for gasoline, oil, tire changes, because those things are presumably very affordable. You have insurance for insurance. And now, if medications are 95% cheaper, you just need less prescription insurance. You don't need co-pays. You don't need ER visits or urgent care visit when your doctor is available 24/7 for $50 a month. So we just help the insurance company and the employer see how this works, carve back the benefits to find the savings to justify our own. If I can save you money on medicines each month, great, but if I can save you hundreds of dollars over our membership cost per month, even better.
And then John mentioned there are lots of other things going on that are very exciting. We have apps in the Bay Area for on-call, house call of doctors that's $100 and so on.
I was going to say on that last question, employer certainly could pay the concierge fee directly, but for the other costs, they could put money in an HRA, which doesn't have that high deductible that the health savings account requires. And that's a way an employer could pay that for that.
I have one real quick question. Do you have an office in Dallas?
We've started over 250 doctors in this model in the last few years. There's probably 500 doctors across the country doing it. So yes, there's a number of doctors in Texas, Dallas, Fort Worth, Austin doing this model.
Okay, I'll get with you during the lunch. The real question I thought I had to have, is, and I guess I would address it to John, since we've been at this together for how many 100 years, but anybody on the panel. It's one of those things that slaps you in the head, you said, I could have had a V8, or why didn't I think of that before? Words have meaning, and I think everybody in this room has experienced the difference between the public the response to estate tax versus death tax, and the popularity or lack of popularity just by changing the word choice. And it dawned on me when we have coupled pre-existing conditions into an insurance package. Well, pre-existing conditions, when you are, quote, insuring, as we say today, for pre-existing conditions, we're really not. We're demanding that you pay for my existing medicine. But yet we're trying to call it insurance. Insurance is a corporate consolidation of risk about an unknown future. You know you have diabetes, or you know you have pancreatic cancer, or you know you have a disease. That's called pre-existing condition. So we're demanding in this bill that I've paid into this insurance system, and now I'm going to get out and move. I've paid nothing into it, but that new insurer has to accept all the medical expenses that I've already have. Well, that's not insurance. So my question is, why can't we separate those two in the public debate and create, if necessary, some kind of a pre-existing pool that pays for medical care of the known quantity, and then have affordable insurance for everybody else? And don't we really call that Medicaid?
Well, we can do that, and we don't have to do it through Medicaid. But so let's back up. This is a government-created problem. Ever since World War II, we've encouraged people to get health insurance from an employer, but it's group insurance. It's not portable. So you could be paying into your employer's plan for 30, 40 years. Now, you early retirement, layoff, whatever, you leave the employer. Now you go to the group market. You've got a health problem. And as you said, you paid premiums over here. You haven't paid any premium in the individual market. So how are we going to cover your health care costs? The right way, but again, a government-created problem, and I think the government solution is a premium tax on group insurance to fund the high-cost people who move over to the individual market, so that we don't dump all those problems on what really is a tiny little market. It's only 5% of private insurance. And we've been the Texas risk pool dumped into it, federal risk pool dumps into it. Teachers, retirement, they've run out of money in their post-retirement plan. All those folks could dump into this little market. So you're right, we need a funding source. Guys in Congress haven't recognized this, to have the group market subsidize these risk people. And then the second thing we need to do is you can't let people move back and forth among plans at premiums that have nothing to do with their costs. So we need what I call free market risk adjustment. And so if you move from Blue Cross to Aetna and you've got cancer, Blue Cross has to pay Aetna, in addition to your premium, enough to make you enough to cover your actuarially predictable costs. And if we would do that, then we'd have a real market for sick people. You've seen these advertisements on TV, Cancer Treatment Center of America, they say, if you have cancer, we want you. No, that's only if you're on Medicare. If you're in the exchange, they don't want you. So we need that kind of activity in the individual market. So for heart disease, cancer, diabetes, let's have a real market. And if Republicans would talk that way, that for the chronically ill, we're going to make your life better, which is how I hear Trump talking, they would do a lot better than talking about how many benefits they're going to take away from people.
Yeah, just to jump in on that, and because I realized this point reading your work actually, there's sort of an intermediate case between the two extremes you mentioned there, where you could develop a condition, during your life after you had already signed up for health insurance. So with something like life insurance, if you're 25 and you take out a 30-year term policy, you might develop a serious heart condition or cancer or something halfway through, and you'll be glad, I'm glad I locked myself into this 30-year term policy and they can't raise the rates on me. Whereas if you were constantly rolling it over with a 1-year term policy each year, and your health status changed, and all of a sudden you might be uninsurable from a life insurance perspective. And so I just, John was pointing out in some of his work that notice there's nothing really analogous to that right now. It's not that when you're 25, you can buy a health insurance policy that covers you for the next 30 years and locks it in. So no matter what happens, this is your guaranteed premium to have basic insurance.
Well, one more thing. A few months back, Congress passed the Cures Act. And in that act varied, I may be the only person who's actually written about it. If you're a small business, I think it's under 50 employees, you can buy now individual insurance for your employees, which they own. So when they leave your company, they take it with them. And under Obamacare, the fine was $100 per employee per day if you did that. Now that fine does not apply to small business. So my argument to Paul Ryan and these guys is let's do that for all businesses. If we would encourage portable insurance, this problem, pre-existing conditions, would go away.
A couple of questions. I'm assuming you do not have a Medicare contract.
Correct.
How do you interface your office services, lab services, and so forth with a patient who may need care from perhaps a practitioner who is not within your practice, particular type of surgery or diagnostic procedure? And how do you interface that with hospitals who might very well want to have more control over you and not allow you on their staff? And how do you pull that off?
So the general question, how do we sync with the rest of the healthcare system? In a very simple way, we make everything we can affordable, and anything else we can't is insurance. But isn't that true of all insurance? So our ability to negotiate cash rates or discounts allows us to make the vast majority of things cheaper. Again, even chemotherapy we got for a patient 99% less than the brand name retail price, because the generic wholesale was $6 a month. So we do have a broad ability to go out into the system and decrease the cost of a lot of care. Some hospitals, like the Surgery Center of Oklahoma, want to work with doctors who are doing this because they are also working at driving prices down and providing a better value. Hospitals that resist the change run the risk of being like Kodak and going away. Hospitals that embrace free market principles, because now patients have a very high $5,000 deductible, well, they're shopping. They do care about price, and they are sensitive to that. So the hospitals do have an opportunity to compete in a very unique way. They always have their CT staff, their MRI staff, the labs, the pharmacy. So they can provide competitive value if they choose to. So they can't really slow us down or stop us because they still have their insurance contract, so they still do a certain amount of Medicare, Medicaid, etc. So we blend the two nicely. If you do have insurance, you lose nothing by gaining with us. If you don't have insurance, you just have everything to gain.
Josh, I'm a physician. I saw you speak in 2013 at the AAPS in Denver. And so you've trained 500 doctors in your policy, in your methods. How big is Atlas Medical in Wichita now?
Atlas ourselves is 2 locations and 5 physicians. We do all the consulting for doctors free of charge to help nurture the movement.
And I think I understand what you're saying, this gentleman's question. You're just providing the primary care service, and he was wondering if the border was all-inclusive with specialty care. You go to a cardiologist or an oncologist just like you would if I were your internist. And
Correct. Anything outside of our bubble, but we try to put as much into our bubble at decreased cost. So we'll work with orthopedic groups for casting services or cardiology groups for cash echoes. Had a patient pay $2,700 for a stress echo that we got for another patient for $200. So we work outside the system whenever we can, but yeah.
If I could add one more thing. An obvious thing that you would want to do with a health savings account is an employer would like to put money into account, say, for all primary care. I wrote about this 20 years ago. Just put health savings, say to the employee, you are responsible for all primary care. Here's $2,000 or whatever you want to put in the account, and then let the insurance cover the non-primary care. This hasn't even occurred to Paul Ryan and the Republicans. You know, they keep saying we're going to make health savings accounts more available, but they don't do the obvious reform. Related to that is you should be able to put money in account for the chronically ill. So you have a diabetic, put money into account if he's willing to manage his own care.
Well, and that speaks to what Robert said, which is the government keeps, we didn't do enough. So let's push the action down again, and that just has created so much regulation and red tape that doctors, depending on the study, are spending more than 50% of their time on paperwork and not patient care. and we don't have that patient. Any other industry talks about streamlining, improving their product and lowering their price. So now that we can do that to healthcare, a diabetic, we can get 1,000 metformin pills for $11 wholesale. Now the cost of managing your diabetes is a fraction of what it was. The A1C test to measure that's $2.25. So that $2,000 that the employer might give to a patient used to not cover very much care at all. Now with good just business principles, we've increased the buying power of that patient's HSA tenfold. If I may, I think this is what the Republicans are struggling with is, well, we're going to double the HSA options. It's the modern equivalent of let them eat cake. There was another economic study that said most people can't come up with $1,000 for an emergency. So to say now you can donate $12,000 to an HSA, great, I couldn't hit my max before. But if you can make the value of those HSA dollars buy 10 times as much medicine or 10 times as much care, we do stitches for free that the ER would charge $500 for because they cost me $1. You know, urine dipsticks cost me 10 cents. EKGs cost me 36 cents. The coffee in the waiting room costs 60 cents a cup. I should be billing health insurance for coffee. I would make more money in that scenario. So,
We're almost out of time. We have time for one more question over here.
Hi, my name is Christy Horpedahl. I work at the Arkansas Center for Research and Economics, and so we're trying to do some of these things in Arkansas that you guys are doing great here in Texas. In the last legislative session, we pushed for a lot of expansion of scope of practice for nurse practitioners, and we tried very hard to use this win-win model, right? Nurse practitioners can go into rural areas. We have research that shows that doctors don't actually end up making any less money when you expand this pool. And of course, the AMA comes out in force, right? Anytime you want to try to change how these things are happening. So there's really smart, really invested people who are sort of fighting against any of these plans that we have to try to make these win-win deals. And that's something that we're struggling with and trying to figure out how do we do better in 2 years at the next legislative session when they pick these things up again. So if you guys have any thoughts on how do you fight against these really smart, really powerful, really invested people who it's not a win-win for them, and we don't always know how to fight back against that.
Albert's octopus.
No, you know, in Texas, the Texas Medical Association wants to close down Teladoc. And they do not believe that a doctor should be able to talk to a patient he's never met on the telephone. But if Mary and I were in practice together, and I want to go on vacation, and I say, Mary, will you handle my patients while I'm gone, who she's never met? Mm-hmm. And they call in and she can prescribe for them, and let's say she doesn't have any electronic medical records at all. They think that's just fine. But if Teladoc does it, they want to put them out of business. So the AMA and the Texas Medical Association are standing between us and a much better world, in my opinion.
Hopefully, like all good octopi, get out competed. Consumers will be sovereign again. Thank you very much, gentlemen.